You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Welcome to another episode of Beyond the Abstract. In today's episode, we're talking to Dr. Christine Neeb about her recent article, Integration of a Community Opioid Treatment Program into a Federally Qualified Health Center. Dr. Neeb discusses integrated opioid treatment programs and how this model can potentially be adapted to other patient populations with substance use disorders. Dr. Christine Neeb is a visiting associate professor and the director of Integrated Primary Care and Addiction in the Division of General Internal Medicine at the University of Colorado Anschutz. She's board certified in family medicine and addiction medicine and focuses on novel strategies to expand access to treatment of substance use disorders, including methadone maintenance therapy in underserved populations and in the primary care setting. Now let's get into today's talk with Dr. Christine Neeb. Can you share a little bit about what was it that got you interested in this field, and what have your experiences been like over the time, over the course of your career up until this point?
Sure. So I actually did not have addiction medicine on my radar when I was training. I went into family medicine, mostly looking at what were called READY programs that train family medicine physicians to do abortion care. And I ended up choosing University of Illinois in Chicago and got pretty extensive training in abortion care. And after graduation, I incorporated that into my practice when I was in Washington, D.C., and was actually finding that in some of those areas that are more like saturated with abortion providers, I wasn't necessarily needed to do that care. They have plenty of access there. They have plenty of excellent physicians and clinics that provide reproductive services. And so I felt like I was doing that more for me rather than for the community. And I found that, especially in the area that I was working in, I was working at an FQHC in Washington, D.C., there was a significant issue with substance use disorders, and particularly with fentanyl was increasing at that time, because this was about eight or so years ago at this point. And there was an opportunity to get a DATA 2000 waiver, which was needed at the time, and I did that and found that I really, really enjoyed working with this population, and it kind of satisfied the kind of social justice area of medicine that I was interested in, as well as just more nerdy pharmacology and medicine aspects. And so I just kind of went from there and moved back to Chicago, probably like a year after that. And the clinic that I was working at, the FQHC, was really ramping up its substance use disorder treatment options. And I became involved in that and just kind of went from there and found that it was just really enjoyable and very rewarding area of medicine.
Yeah. Well, I want to ask you because one of the things we're going to talk about today is integrated opioid, kind of treatment care. So can you tell me a little bit about how can integrated opioid treatment program and federally qualified health center models kind of address the opioid and overdose epidemics?
Yeah. So I would say I wouldn't say it's super easy to do because, as anyone knows, like, opioid treatment programs have a lot of both state and federal regulations, but they really do meet a specific niche, which seems to be these underserved populations with a lot of chronic medical problems. And I think sometimes we think of opioid use disorder as really affecting younger people, particularly, people in their 20s who are using fentanyl. But in a lot of cities, like, this problem has been going on for a really long time. We think of the waves of the opioid crisis, and that chart starts in 2000. And that's not true. This has been going on for many, many years. And so in some of our cities, we have patients who have opioid use disorder who are in their 50s, 60s, 70s, and they are facing both the need for medications for opioid use disorder, as well as all the other chronic medical problems that anyone in their age group faces. And so integrating these into one place really gives our patients the option to get care for all of their needs rather than just one or the other. And in particular, for a lot of our patients, transportation is a major issue, and they might not be able to go to both their primary care doctor and an opioid treatment program, especially if they need to go every single day, depending on what rules that individual OTP has. And so I think this integrated program is really meeting that need, and allowing our patients to get all of their care in one place.
This integrated program, it was designed to serve patients with complex medical needs and co-occurring conditions like comorbid opioid use disorder and chronic health conditions. Can this model be adapted to other patient populations with substance use disorders and potentially reduce health disparities, like, for example, among minoritized populations or patients with AUD, alcohol use disorder?
Yeah, I think it could be used to really match whatever needs are in an individual community. I mean, I imagine this kind of program could be used for pregnant and parenting people. That is a huge need, and a lot of people with opioid use disorder need methadone when they're pregnant. Could be used for chronic pain, could be used in clinics serving people with more severe mental illnesses. Um, and for to use it for illnesses such as like alcohol use disorder would actually be even easier than using it for to do methadone for patients with opioid use disorder, because you wouldn't have to deal with all the regulations to set up an OTP. Alcohol use disorder, I think, really fits well in this model, because a lot of our patients with alcohol use disorder have uh, have chronic illnesses due to alcohol use, right? So we have patients with decompensated cirrhosis, um, uh, GI bleeds, neurologic complications, all of those things that really need a primary care doctor to be on top of. And so in my current clinic, I see a lot of those patients. It can really help them navigate the medical system until, for instance, maybe they are ready to receive a transplant if their liver disease has gotten that severe. And I think we don't have enough of these type of clinics around to give the patients the support that they need to really address all facets of their illnesses.
Right. So talk to me about this. What are some considerations? What are some potential barriers to adding opioid treatment programs to like a primary care setting?
I think the biggest barrier for methadone is going to be finding a partner who is an OTP who wants to do this. I think, but there are lots of people in our OTPs that have found this really interesting, and then navigating the DEA regulations, both and the state regulations and the federal regulations, which we were lucky for our project. Family Guidance Centers, who that's the OTP that we worked with, they were really incredible and know exactly what they're doing, and they were able to help navigate that process. And so just leaning on the expertise of your partners, each of the stakeholders here, was really, really helpful, because, for a federally qualified health center, we know a lot on community health. We know we know a lot about primary care, but we might not know all the different rules to bring a methadone clinic in. So that, I'd say, is the biggest barrier on that end. And if you're looking at just bringing opioid use disorder into the clinic in general, most clinics are going to start with just buprenorphine, right? Where they're not going to jump feet first into methadone. And that's a lot easier to incorporate because it's not really regulated the way it used to be. It's really a lot more, the barriers are about stigma, getting your clinic leadership on board, and then potentially provider education if the providers in your clinic are not comfortable with that yet. But there are lots of opportunities out there to get providers educated through, even though the DEA requirement for the Data 2000 waiver has gone away, there's still plenty of CME available to get you jump started. There's different ECHO programs. And really, you just need one or two advocates in your clinic who really want to get this started. And you can start small and then continue to expand from there. And I think once it is incorporated, people start to be less afraid of it, and start to realize what a benefit it is for their patients. And they start to see that it actually makes their lives easier to be able to offer this service rather than to need to just, be really uncomfortable every time a patient with opioid use disorder comes into the clinic.
Right. Well, now looking down the road, what kind of future research questions came about and emerged from the study, and what kind of studies do you think would maybe kind of be able to address some of these questions that arose?
I have a lot of questions, future questions in terms of research. But to be fair, I mostly do clinical work and then kind of do research more on the back end. I do a lot of kind of like retrospective looks at programs that I've developed to see what our outcomes were. But I would love to see if this kind of integrated program improved our dosing adherence in methadone. We looked at retention in methadone treatment, which is a really common outcome to look at when you're looking at methadone treatment. And we saw that it was essentially equivalent between the OTP and our FQHC. But seeing if patients were more likely to come in and dose at the primary care clinic, and then looking at primary care outcomes, because ultimately, as a family medicine physician, I am very interested in primary care, of course. And so seeing does it improve our immunization outcomes? Does it improve cancer screenings? Does it improve control of behavioral health conditions, anxiety, PTSD, depression? And then does it reduce stigma for the patients? And I think these would be relatively easy to do, just like pulling data out of whatever your electronic medical record is and doing some retrospective analysis. It's just going to take time and have these programs in place for a while before we can actually get that data. And then ultimately, of course, we'd love to show that incorporating these two, incorporating opioid use disorder treatment and primary care together are going to improve outcomes overall. So, we don't want to treat opioid use disorder just to have someone, die early of colorectal cancer. So can we show that incorporating those two together improved our screenings and then ultimately improved our outcomes for our patients and helped them live longer and healthier lives? But that will take a long time.
Well, Dr. Neeb, already such a wealth of information in this episode, but I've got to ask for a little bit of advice. We'd like to close out with some wisdom from our providers and our physicians here. So what advice would you give, looking back, what advice would you give to your younger self, maybe earlier in your career or even pre-med, getting into this space? And what advice do you think you would impart onto the up-and-coming generation of addiction medicine professionals who are just getting involved in this area, in this arena now?
Yeah, I think especially when you are in medical school or applying to residency, there's this feeling like you need to apply to the exact right program and get all of your training and residency, and that's it. And that your knowledge is kind of static. But really, in residency, in medical school and residency, you're going to learn how to think about medicine. You're going to learn, how to become a lifelong learner. And just because you don't learn the exact skill that in residency doesn't mean that you can't change that later, right? So I feel like as a family medicine physician, we really learn how to think, how to serve the community, and we're really adept at learning new techniques, incorporating new knowledge. And I was able to make a career in a field that I really had very little training in, which I think is really important to remember when you're kind of panicking going into residency and applying. All trainees, I'd say, just you can change your career, you can adjust to fit whatever your interests are and the needs of your patients at any time. And that's okay.
That's awesome. Dr. Neeb, thank you so much for stopping by the show and speaking with me today.
Thank you so much.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.